Hi there. Welcome again. Thank you all for joining us. My name is Dr. Edward Kafkarian. I'm the co-chair for this year's Elevate, and I'll moderate this session. It's called Insomnia in Patients with Psychiatric Disorders, Causes, Consequences, Best Practices, and Emerging Treatments. So does anyone have I wonder if anyone has any patients that have ever complained of insomnia. I know I have. So this is a very relevant lecture for us all. I'm very excited about it. This session is supported by an educational grant from EZI. And while I introduce our speakers, if you haven't already, please take a moment to answer the polling questions to the right of your screen. These questions will be asked again at the end of the program. We appreciate your participation in them. And so now I'd like to introduce our illustrious speakers, Dr. Craig Chepke, MD. He is Adjunct Assistant Professor of Psychiatry, University of North Carolina School of Medicine, Fine Institution, Medical Director of Excel Psychiatric Associates, I'm sure also a fine institution. And he's out of Huntersville, North Carolina, a beautiful part of the country. I also had the pleasure of introducing Dr. Carl DeGrange. He's professor of psychiatry, neurology, and medicine, and medical director at Jefferson Sleep Disorder Center, Thomas Jefferson University, and one of the hearts of healthcare in Pennsylvania there, Philadelphia, Pennsylvania. So now, at the end of the session, both Dr. Chepke and Dr. DeGrange will join us for a live Q&A. You can type in your questions in the Q&A box to the right of your screen, as well as upvote questions submitted by other attendees if you want to see their question answered. They will try to answer all of the most popular questions with the time remaining at the end. So without further delay, let's begin the session.
Hello, everybody, and welcome to this presentation on insomnia in patients with psychiatric disorders, causes, consequences, best practices, and emerging treatments. This is our disclosure slide. I'm sure those of you who have syllabi can see this in your syllabus as well for details. And a statement regarding disclosure. These are our learning objectives. Today, we are going to evaluate common root causes and the link between insomnia and psychiatric disorders. We'll be reviewing guideline-directed best practices for treatment of primary insomnia. We'll also discuss current and emerging agents for the treatment of insomnia, including their pharmacodynamics and safety efficacy data. My presentation is entitled The Burden of Insomnia, an Overview, and Dr. Chepke will then speak more about the issues with treatment. First of all, I'd like you to meet Jane. Jane is a patient of mine who's a 67-year-old woman. She's had a lifelong struggle with insomnia and a number of other comorbidities. And Jane is describing to us is talking to us, I should say, about some of the issues which she struggled with, which are associated with insomnia. Here she is.
Most difficult problems that I had prior to finding treatment was with, and this is a little embarrassing, but with snoring. I had a very serious problem with loud snoring to the point that it made me reluctant to even go on vacations with friends because I knew I could potentially disturb them. And I did frequently. So that was, and it took me a long time to understand what the cause of that problem was. Another really difficult problem was that I simply wasn't sleeping. I was averaging maybe a couple of hours a night because if I could fall asleep, I'd only stay asleep for a few hours. And then I would wake up and would not be able to go back to sleep. So I spent my entire days yawning and being tired, but never being able to catch up on that sleep or to feel refreshed.
Okay, so you can see how Jane's struggle with insomnia has been problematic for her. And it's, of course, a sleep maintenance insomnia characterized by waking up a lot during the course of the night. And you can also see how she complains of unrefreshing sleep, daytime fatigue, and that sort of thing. Now, what is insomnia? Well, the DSM-5 describes insomnia as a disorder, insomnia disorder, characterized by dissatisfaction with sleep quality or quantity. So people struggle with not sleeping enough or struggle with feeling unrefreshed when they wake up qualitatively. And they have difficulty with initiation of sleep or maintenance of sleep, or simply waking up and unable to fall back to sleep. So this is criterion number one. They also have significant impairment during the course of the day or distress with the symptom. There are many people who sleep for short periods of time, but really don't have any impairment during the day. They don't have any feelings of fatigue. They don't have any cognitive or other impairments. And technically, that's not insomnia. Frequency criterion, more than 3 nights per week. Duration criterion, more than 3 months in duration. And adequate opportunity for sleep, to distinguish this from shift workers who, of course, can't sleep or don't sleep because they're not in bed long enough. And finally, and importantly, the DSM-5 allows for coding of comorbidities, disorders that occur with insomnia, things like depression, medical disorders, making the point that the DSM-5 no longer distinguishes between secondary and primary insomnia disorders. Anything that coexists with insomnia as a disorder can be coded with it, with the understanding understanding that they may be related to insomnia or not related to it, maybe contributory to it or not contributory. In fact, insomnia may contribute to them, but we code these independently with insomnia as comorbidities. Important understanding regarding the coexistence of other disorders with insomnia. How common is this problem? Well, about 33% of the population, a third of the population, struggles with insomnia on a daily basis. So a highly common problem, the second most commonly reported complaint in all of mankind. And importantly for us as mental health professionals, a third of our patients, outpatients, have insomnia, about a third, and about 70 to 80% of our inpatients struggle with insomnia, as studies have shown. So very common problem in psychiatric settings. Insomnia is characterized by the presence of comorbidities. A number of other disturbances occur with insomnia. These have to do not only with medical and health conditions, but also with habits, lifestyle habits, attitudes, misperceptions about insomnia. And Craig later on will be going over about how addressing these misperceptions and habits can really help us impact insomnia. But the other point to be made on this slide is that we as clinicians need to be aware of these comorbidities and be detectives when it comes to insomnia, identify these comorbidities and manage them conclusively to be able to really get rid of insomnia. And many of these comorbidities are outside the realm of our discipline. The patient with insomnia could have a snoring problem, could have apnea, could have a medical thyroid condition. So we need to be on top of this as health professionals. And here are some of the conditions that insomniacs have. More so than non-insomniacs: diabetes, breathing problems, cancer, so you name it. So we need to really be on top of other medical issues when it comes to insomnia. And as I mentioned before, insomnia's consequences, insomniacs can't enjoy life. They have absenteeism from work. They have difficulty with cognitive performance, motor vehicle crashes. I'll show you a slide on that. Increased risk of falls. Elderly who have insomnia are at greater risk of falls and hip fractures than those who do not have insomnia. On the right side of the screen, increased risk of accidents and pain. Insomnia decreases the pain threshold. So in other words, if you have insomnia, you're more likely to feel your pain disorder and feel pain. And conversely, if we restore sleep, pain is less of a problem. So it's important to look at pain. Insomnia rather, in the pain disordered patient. And well, I'll make another point of this, that insomnia has a seemingly bidirectional relationship with psychiatric disorders. Insomniacs are more likely to develop psychiatric disorders in the future. I'll talk more about that. And are more likely to develop high blood pressure and diabetes in the future. And interestingly, have a higher mortality rate. So insomnia is not an innocuous condition. It is associated with all sorts of comorbidities that occur later on in the struggle with insomnia. Here's the slide on driving performance. On the top are insomniacs, on the bottom are good sleepers. Insomniacs have a greater weave factor. They have a higher of what's called standard deviation of lateral position. They weave back and forth more when driving cars. So they have a high risk of accidents when they drive cars. And also, as I mentioned before, chronic insomniacs have a higher risk of developing high blood pressure, hypertension. And we think this is related to the insomnia pathophysiology, that insomnia is a disorder of hyperarousal, brain hyperactivation, which translates into sympathetic activation, which in turn drives up blood pressure. So important physiologic consequences of having insomnia. Now, this is a bit of a complex but important slide. And what we see here on the left side is the brain while awake, and on the right side with the brain while asleep in non-REM sleep. And this is a slide comparing insomniacs to controls. So the orange part of the slide on the left side depicts fluorodeoxyglucose metabolism on PET scanning, or brain metabolism on PET scanning, basically showing that while awake, insomniacs have a higher brain metabolism than controls. I mean, that's not something which we're surprised by, right? Insomnia is characterized by hyperactivation of the brain. On the right side is the brain while asleep. Notice that even while asleep, insomniacs have a greater activation than non-insomniacs in various parts of the brain. And they have this orange area represents brain activation. So insomniacs, while awake or asleep, have a higher brain metabolism than non-insomniacs. Again, hyperactivation of the brain in insomnia while awake or asleep. Now, hyperarousal, I should say, not hyperactivation. Superimposed upon this orange area are some of the pathways governing wakefulness. Those are the pink areas, diagrammatic pink areas. The ascending reticular activating system, which is innervated by histamine, norepinephrine, epinephrine, serotonin, acetylcholine. All of these areas are involved in waking us up, arousal. Notice that there's something called ORX. This is the orexin system. Many of you may not be familiar with this. The orexin system, these are cells located primarily in the hypothalamus, which impinge upon the other areas and control the transition between wakefulness and sleep, and also are stimulating pathways that arouse us, orexins. Notice that these arousal systems, including the orexins, when they're superimposed upon that slide of PET scanning, are very much in the geographically, very much in the areas that control arousal. So we think indirectly that insomnia is a disorder of hyperarousal of these brain activation systems. In fact, there are some data suggesting that orexin hyperarousal, increase in orexin levels, is characteristic of insomnia. Later on, Craig will talk a little bit about about hypnotic medications and how they might antagonize some of these systems and help insomniacs with sleep. Okay, let's now go on to explore some of the relationships between insomnia and psychiatric disorders. So when we look at insomniacs, they have a higher rate of various psychiatric disorders, right? Alcohol abuse, dysthymia, major depression, anxiety disorders. So mental health disorders are common in insomniacs. But from this other side of the coin, many people with emotional disturbances have insomnia. For example, 90% of depressives struggle with insomnia. In PTSD, nightmares, fear, avoidance of sleep is very common, and people struggle with insomnia because of these disturbing nightmares. In ADHD, difficulty with task performance is common, but during sleep, ADHD children wake up and struggle with sleep. So insomnia and psychiatric disorders are very commonly associated with one another. Just focusing on major depression for a second, insomnia, as I said, is something which afflicts 90% of depressives. But interestingly, longitudinally, it's more likely to emerge before the emergence of a major depressive episode. So longitudinally, over the course of time, and a person with major depression tends to first struggle with insomnia without depression, and then depression comes along. And interestingly, after the resolution of depression, often insomnia persists. And this is a common problem as well. So we think that there may be this bidirectional longitudinal relationship between insomnia and depression. Insomnia then foments depression potentially, and then depression may foment insomnia in turn. This is a very, very common problem. Here's some data showing us many, many different studies, longitudinal studies with depressants, showing us that in depression, there is this increased odds ratio of insomnia in the future. So depressives have a 2 or 3-fold higher likelihood of insomniacs have a 2 to 3-fold likelihood of developing depression in the future. So a common problem that is a bidirectional problem. Suicide. Insomnia is a predictor of suicide independently of depression, which is a very interesting finding. And this is true with adolescents, adults, and even older adults. And the mechanism by which insomnia may lead to suicide may be this sense of thwarted belongingness and hopelessness. Insomniacs struggle with the sense of being abandoned and not belonging. And when you think about it, lying in bed when the world is asleep while insomniacs remain awake seems to aggravate this sense of not belonging, being alone and struggling alone. And in the context of major depression, as I said before, insomnia is a very common residual symptom. When you look at people with insomnia after the resolution of, when you look at people with depression after the resolution of their depressive episode, after depression is gone, one of the biggest things they struggle with as a residual nagging symptom is not sleeping well. And this symptom predicts the onset of another depressive episode. So important thing to look at. Here are the data on that. People who have residual insomnia after the resolution of depression have a much higher rate of the recurrence of another depressive episode. So we need to, when we're seeing depressives, we need to really look at their insomnia carefully. In the bipolar patient, insomnia predicts the onset of a manic condition, mania. Now, I've said that insomnia is a predictor of depression. How about from the other side of the coin? Does treatment of treatment of insomnia in some way help depression? And there's some indirect but pretty good data suggesting this might be the case. The third bullet point on the slide here, S-zopiclone. There's a nice study with S-zopiclone, which is a sleeping medication, showing us that patients who are on fluoxetine, which is an antidepressant, if co-treated with S-zopiclone, have a much better rate of remission than patients who are not on S-zopiclone. So S-zopiclone actually helped them in terms of depression, in terms of relieving depression sooner and better. Now, S-zopiclone is not indicated for the treatment of depression. So it's not an established treatment for this. But for us, these data imply that benefiting sleep or improving sleep in the depressed patient may be a very important part of their treatment regimen, that we should not ignore sleep, but make that an important aspect of our treatment armamentarium with the depressive patient. And in the context of suicide, these data, the very interesting data that has just emerged by Dr. Von McCall, suggest to us that treating insomnia in the case of the depressed patient who has insomnia may actually diminish suicidal ideation. This was a very nice study. And on the right side, we're seeing data from the Columbia Suicide Severity Rating Scale in patients who actually had their insomnia managed by with zolpidem controlled release, had actually diminished suicidal ideation compared to those who were not treated with zolpidem. And of course, all of these patients also were treated with an antidepressant for the depression. So it's important, I think, to look at insomnia as something that is a target of our management in the patient with depression. I'd like to stop at this point and turn the presentation over to my colleague, Craig Chepke, who'll be talking about treatment of insomnia following guideline recommended best practice. Craig?
I'm really excited to be here today to bring you this presentation about insomnia. I know in my clinic, I've seen a tremendous increase in the patients who have had trouble sleeping as a result of the lockdowns and COVID, and I'm sure you probably have in your clinic as well. So I think this is a very relevant topic to be examining here. So we're going to take a look at following guideline recommended best practices for the treatment of insomnia. And one big problem that we have as mental health clinicians in treating insomnia, I think, is that we don't really know how to treat insomnia very well. And really, in some ways, it's not really our fault. For most of the history of psychiatric treatment, that we always could rely on having a sedating antidepressant, a sedating antipsychotic, or some other medication that we kind of got the sedation for free, so to speak. And as a result, we didn't have to learn how to treat insomnia as an independent entity in many cases. But now with newer medications having had the rational design to reduce the amount of sedation, then many of our patients are struggling with insomnia. So we're going to take a look at how we can treat that better. So we already met Jane and saw some of her struggles with insomnia, and I was really struck by just the desperation and the struggling in her voice. And that was before she started to seek treatment. And now we'll take a look at when she was met a clinician to try and help her with her sleep and some troubles that she faced there.
I finally was prescribed with some medication, several different kinds of medication initially, and they did help me sleep. And that was a big relief, but they also made me feel groggy. I became used to just experiencing grogginess all the time.
So you can really hear the frustration in her voice as she talks about her struggles to find the right treatment. And this is a frustration that patients may live with and not necessarily bring up proactively. So I always tell every patient I work with that sleep is the foundation of mental health. And without a good foundation, your whole house will crumble. Similar to how Carl talked about before, just the problems with depression and other comorbidities. So I don't let a patient leave my office without asking about their sleep, whether it's our first appointment or whether we've been working together for 10 years. So the first line treatments that we may consider can be non-pharmacological. So the gold standard behavioral treatment is CBT-I, CBT for insomnia. So this is a specialized offshoot of CBT, which is specifically designed and validated, proven to treat insomnia very well. Some of the problems include, though, that it requires 6 to 8 in-person visits over 8 weeks, which right now, for many of us doing telemedicine, is difficult to begin with. But then also, I don't know how it is around the rest of the country, but where I live and practice in Charlotte, North Carolina, CBTI is very hard to access for my patients, so it may not be available. So there have been a couple methods that have been designed to try and increase access to behavioral treatments for insomnia. One is an unguided CBTI via smartphone. And this is going by the name Somnus, previously known as Shut-Eye in the trials. And they validated this over an 18-month period to treat insomnia without having the specialized in CBTI therapist. And this actually just recently, a couple months ago, was cleared by the FDA to treat insomnia, but it's not yet actually available for us to prescribe as a prescription digital therapeutic. Soon, though. And then there's yet another offshoot, the brief behavioral therapy for insomnia. So this was actually the initial efficacy study was done by a nurse practitioner with no prior experience in either sleep medicine or behavioral treatment for insomnia. So the take home there is that this is something that anyone can learn how to do and access for their patients. You don't have to have a long history of being educated and trained in sleep medicine. And it reduces the in-person visits and telephone sessions down. And there actually is even a trial of BBTI delivered completely over telehealth that's going on right now. And then exercise is extremely important for everybody in most mental health conditions, but insomnia as well. There was a recent meta-analysis in the aging population showing that even just moderate intensity exercise a few days a week produced a lot of significant benefits and didn't have to be a very long time, 20 to 70 minutes, and things like Qigong, Tai Chi, yoga showed efficacy. And you can see on the right, there's some of the efficacy parameters that there were a lot of significant benefits in the studies that were shown. And the standardized effect size down there, Cohen's d of 0.8. Just for comparison, that's up there with the psychostimulants in ADHD, which are generally considered some of the largest effect sizes in psychiatry. So exercise can have a tremendous impact on the symptoms of insomnia. So turning to pharmacotherapies, this slide will list the FDA-approved pharmacotherapies. And first off is the benzodiazepine receptor agonist, which we would colloquially call just the benzos. There are 5 that are FDA-approved. The one that I see most often out of these 5 is temazepam, although occasionally triazolam, previously known as Halcyon. Though to be honest, most of the patients I see on a benzo for sleep, it tends to be alprazolam or clonazepam, even though those don't have an FDA indication. Next, they were developed the non-benzodiazepine receptor agonists, or we might call them the Z drugs. And there are 3 of them there, esoquolone, Zalplon, and Zolpidem. Then there's also a melatonin agonist, Remeltion, and a selective histamine 1 antagonist. And this is actually doxepin, the tricyclic antidepressant, but at a low dose of 3 or 6 milligrams. And at that dose, the selectivity is 100-fold over the next most tightly binding receptor. So that's on par with the SSRIs in terms of selectivity. So very selective for just the H1 receptor at those low doses. And also in terms of the aging population, 6 milligrams of doxepin is the highest dose available that does not fall into the Beers list of potentially inappropriate medications for older adults. And finally, the most recent category of meds are the dual orexin receptor antagonists. Carl mentioned Orexin previously. We'll have a number of slides about that. We'll talk more about it. Very interesting category of meds. There's 2 at the moment, lemborexin and suvorexin. So every medication has limitations, and those for insomnia are certainly no different. The benzos, those I think are very clear to probably most of us here. There's abuse and dependence risk, perhaps respiratory depression, particularly important in insomnia. Daytime cognitive and psychomotor impairment is a significant problem that many patients may not realize is coming from some of their benzos at night, many of which have very long half-lives or metabolites with extremely long half-lives. The Z drugs, conceptually, they have kind of similar limitations to the benzos, maybe in some different proportions or magnitudes. One that you may have heard recently crop up is there's always been the risk of complex sleep behaviors with the Z drugs. But in April of 2019, the FDA strengthened that warning from a regular warning to a bolded boxed warning, which you can see what that looks like here. I pulled the one for zolpidem, but it's on all 3 of the Z drugs. And this is something patients may have heard of and may ask you about. So it's important to understand that warning. The melatonin agonist, Remeltion. So many pharmacotherapies for insomnia may help with both sleep onset and maintenance. Remeltion has efficacy for maintenance only. And in terms of the drug-drug interactions, it's metabolized by cytochrome 1A2, which can be induced by smoking, whether cigarettes, marijuana, or any inhaled hydrocarbons. Now, if our patients are smoking that late into the night, or when they wake up in the middle of the night, which I do see happen, of course, that's very poor sleep hygiene. So patients need to be educated about that. But also, it could affect the concentrations of the Remeltion as well. Doxepin at low dose, that's one that's only efficacious for sleep maintenance. And while we may think that such a low dose may not have very many adverse effects, there is actually a fairly significant risk of next day sedation, which we can't ignore. The orexin antagonists aren't listed here because I do have a number of slides about those in just a minute. So in terms of guidelines, the American Academy of Sleep Medicine did issue treatment guidelines in 2017 of what they found that was recommended and the treatments that they did not recommend. And they were categorized by what the patient's predominant sleep problem was. If it was predominantly sleep onset, there were those drugs listed there. Predominantly maintenance, then the doxepin low dose and suvorexin. And then if patients had both, then the recommendations were slightly different there. Now, of course, if patients had only problems with sleep onset, then the patient could be prescribed a medication that had both onset and efficacy maintenance. So do keep that in mind. What was specifically not recommended was diphenhydramine. It's sold as Benadryl, Tylenol PM, Advil PM, ZQuil. It's got many different over-the-counter preparations. Very commonly, patients will use that and also commonly may not tell us about that, I found. So I asked specifically about those medications when I'm evaluating someone with insomnia. Tiagabine, we don't hear much about in mental health. It's an anticonvulsant, but it has been used off-label for insomnia. Some of the herbal treatments that patients may use, melatonin probably being the most common that I see, but that don't have evidence of efficacy and are not recommended. This is an interesting one, suvorexin. So it's actually FDA approved for both onset and maintenance, but the AASM guidelines only recommend it for sleep maintenance insomnia. And that has a couple reasons, but mostly because the evidence for the sleep onset efficacy is not nearly as robust as it is for the sleep maintenance insomnia. Now, here's probably the controversial one, trazodone. Trazodone, to my knowledge, is actually the #1 prescribed insomnia medication in America, but it's in an off-label fashion. And we'll take a look at some of the potential drawbacks specifically that trazodone could have in the next slide. And then they did also evaluate, but did not make a formal statement on quetiapine. So what are these limitations that I mentioned? So trazodone, there really isn't good evidence of its efficacy. we have anecdotes, but guidelines are based off of evidence, not anecdotes. And then also there was a recent study that was done in the VA system where they did a retrospective analysis of over 300,000 patients treated with the hypnotic. And they actually found that the suicide attempt hazard was 61% higher than low-dose trazodone, which we would assume that doses below 200 milligrams would be used for insomnia most likely. So that's a significant proportion, and it in some regards makes sense. It is an antidepressant technically, and all antidepressant medications do have that bolded box warning for suicidality under 25 years old, although this study certainly was not limited to under 25. One potential mechanism might be that the primary metabolite of trazodone, MCPP, is actually anxiogenic in nature, causes anxiety and also migraines. This may not affect every patient, of course, but with it having 2D6 metabolism, someone who is genetically a poor metabolizer, 2D6, or on a poor 2D6 medication, a 2D6 inhibiting medication, that is, which are very common, fluoxetine, paroxetine, bupropion, they could have higher concentrations of MCPP. And I have seen this in practice a couple times, and so important to keep in mind. Patients may not make that link, and clinicians may not as well. For some of the other treatments, melatonin, again, there's not very much actual evidence of its efficacy despite its widespread use. Also, I think it's very interesting that the physiologic dose of melatonin equivalent endogenously would be between 0.1 and 0.3 milligrams. I'd say the most common dose of melatonin I see patients coming in saying they're taking is 10 milligrams, which is 100-fold what the actual physiologic dose is. And we're not really clear on what the consequences of those are. Remember, melatonin is a hormone. And there is some evidence to show that it may impair glucose tolerance, so not necessarily as harmless as it may be believed to be. Quetiapine, again, poor evidence despite all the anecdotes, but the adverse effects, I think, go without saying, significant metabolic issues, anticholinergic side effects, and then tardive dyskinesia as well. So in terms of orexin antagonists, for the treatment of insomnia, this is the newest class of medications for insomnia treatment, and I think a really exciting one. So I want to talk about the mechanism a little bit more and also the clinical data. So Carl mentioned the orexin system and showed a diagram similar to this with the hyperarousal of insomnia, and patients with insomnia having greater degrees of the hyperarousal, both when awake and asleep. So orexin is a fascinating neuropeptide. Two different research groups were studying it without knowing that they were studying the same thing. And this was actually just in 1998. So to go from discovery of this neuropeptide in 98 to having now 2 FDA-approved agents just 22 years later, I think is really remarkable. So the neurons originate in the hypothalamus mentioned, and they project to a number of different wake-promoting systems of the brain. I think of orexin kind of like the master puppeteer of the sleep-wake cycle, that it projects out to more or less all of them and can modulate them to some degree. The specificity of orexin, I think, is something that is really cool. So if we're using GABAergic medications for insomnia, well, GABA effect is involved in maybe as many as 50% of the neurons and synapses in the brain. And treatment with a GABA agonist can have a lot of unintended consequences. However, on the other hand, only a few tens of thousands of neurons in the brain are orexin based in nature. So much more specific and selective for the sleep-wake cycle than using GABAergic or histaminergic medications. Now, what is the function of the orexin pathway? I mentioned as a puppeteer, and what it does is that it can help to either stabilize or not stabilize the wakefulness system. So when the orexin neuropeptide levels are high, it stabilizes those parts of the brain that are active in wake promotion. So some of those that were mentioned were norepinephrine, serotonin, and histamine agonism is wake promoting. So that's kind of like, you could give the analogy of the gas pedal of the brain. And in these diagrams, when one of the seesaws is lifted up, that's the system that is promoted. So orexin will stabilize wakefulness. When orexin levels are lower, or if it's blocked pharmacologically, then that stabilization of the wake system decreases and allows the sleep system to predominate. At least that's how it's supposed to work in people without insomnia. But as was mentioned, then there's a theory that it could be that patients with insomnia may have excessive hyperarousal, which could be underlied by that orexin. So to break that down into layman's terms, the way I tell patients is that think about sleep like driving a car. So many treatments for insomnia are kind of like pressing on the brake pedal harder. And that may work for some, but if your body is still pressing on the gas pedal at the same time, it's not going to be very effective. So we think that orexin antagonists may work by reducing some of that hyperarousal, and the analogy for that would be like lifting your foot up off the gas pedal. So the first of the two orexin antagonists is suvorexant, and that was approved back in 2014. So I won't do a detailed analysis of its data, but just a few key points about it. One thing that's important is that a large percentage of patients in the trials were over 65. So for those of us who do see a large number of geriatric patients, having medications that were studied in that population, I think is very important. And it antagonizes both orexin receptors, and the most common AE is somnolence, which one would expect for any hypnotic. But interestingly, that women actually may be more susceptible to certain AEs than the males who take the medication. And somnolence is one of those adverse effects. There were some specific safety studies that were looked at that showed no difference from versus placebo for several important factors, like the morning driving performance as measured by the SDLP. And the new data for suvorexant is that in January this year, the FDA approved a label update. There was a study done in patients with Alzheimer's disease that was mild to moderate who did have insomnia. And there was a significant improvement in the sleep time and wake after sleep onset for those patients compared to placebo. The reduction in sleep latency was not significant in that study. And the adverse effects, and one thing to keep in mind is that 77% of the patients in this trial had been escalated to 20 milligrams suvorexant, the highest FDA approved dose. And somnolence was relatively rare at 4% versus 1 in placebo, so a fairly good tolerability profile. Turning to lemborexant, the new kid on the block, approved in December, but not actually available to prescribe until just the beginning of June. It's also a Schedule IV controlled substance like suvorexant, also approved for both onset and maintenance, and antagonizes both orexin receptors. It also had 2 clinical trials, one of which was a 1-month study in the aging population, over 55 for women and 65 for males, and then a longer-term study, 6-month placebo-controlled, and then a 6-month extension for a total of 12 months. Again, somnolence, most common adverse effect. And if we were to convert these percentages over number needed to harm, which I like to do, and a lot of you might as well, number needed to harm for the 5 milligram dose was 17 for somnolence the next day. And then number needed harm for the 10 milligram dose was 12. There are also some special safety studies done showing some good tolerability, including auditory awakening threshold. And also looked at in sleep apnea, at least mild, but hasn't been evaluated in moderate to severe sleep apnea or COPD. Turning to the results of the trial, sleep onset efficacy first, helping patients fall asleep. And then the results over here on the left, one thing to keep in mind with the next 3 slides is that the going down is better, that a lower number indicated by a lower bar on the study is more favorable. So lemborexant 5 and 10 were compared to placebo. And then also you'll notice a green line, which there was a zolpidem active comparator of zolpidem CR, not a direct comparison, but a active comparator. And both doses of lemborexant showed efficacy at day 30. One thing about this though is this was by polysomnography. And I found that patients tend to not really care if the EEG shows that they're falling asleep faster. What they care about is, do they think it works? But it was also evaluated in subjective sleep onset latency. So evaluating, do patients think that the medications help them fall asleep faster? And also there, lemborexant also improves the sleep onset latency subjectively by patient report. And, I mentioned patients prefer to measure by that, but I think as clinicians, we do too. I've never started a sleep med on somebody and send them to a sleep study to see, is that sleep medicine working? I ask them, how do you think it's working? Then we also looked at the sleep maintenance. This was measured in WASO, wake after sleep onset. How much time are patients spending awake after they initially fall asleep? And there we also see in a 1-month study that lemborexant 5 and 10 versus placebo. The one on the right, the WASO 2H, is the wake after sleep onset in the second half of the night specifically, potentially relevant for people who complain of waking up way too early in the morning and not being able to fall back asleep for one. They had some longer term data as well. There's 6-month placebo-controlled data of sleep onset subjectively, and there was efficacy there. Also, I like to look at the daytime functioning. I always tell patients sleep is just a means to an end. What is the most important thing is how refreshed and ready to go are you the next day. And the ISI, or Insomnia Severity Index, was designed to look at both the nighttime and the daytime components of sleep. So the daytime functioning subscale, the ISI for lemborexant, showed efficacy versus placebo at month 6, which continued through the 6-month extension. There are a couple other orexin antagonists which are still in the pipeline. Daridorexant, another dual orexin and receptor antagonist. What's distinguishing about that is that it's got a shorter half-life of about 6 hours. Since these slides were made, actually both phase 3 trials did read out with mostly positive results. And then the last one is seltorexant. So it's actually different in that it's a selective orexin 2 receptor antagonist. There is some evidence that orexin 2 antagonism may be more effective for the treatment of insomnia than dual orexin receptor antagonists, although that's yet to be firmly established. And in terms of clinical trials, there is a positive phase 2 study in insomnia, which is what we'd expect an orexin antagonist to be studied for. But really interesting, they're also examining it for major depressive disorder, both versus placebo and as an adjunct. And phase 2 trials there were also favorable. As you'd expect, the results were better in patients with depression who did exhibit insomnia symptoms. And this medication is, the phase 3 studies are being planned as we speak and could be initiating fairly soon. So to start to wrap up, we have to really put everything together in terms of treatment of insomnia. We have to look at a number of factors, like what is their age? Has this medication been studied in the aging population? Is it mostly onset predominant sleep difficulties? Is it more problems with sleep maintenance? If so, is it that it's almost every night? If so, a preventative medication like low-dose Doxepin might make the most sense. But if it's only a bare number of nights per month, then giving something every night might not be necessary. And an on-demand PRN medication like low-dose Zolpidem sublingually, which is approved for this indication, may be a better fit to reduce the overall med burden for the patient. Or is it both onset and maintenance? Then our choices might be different there. Also, are there other needs that the patient has? One that I actually hear a lot is that the patient wants to be able to wake up in the middle of the night if they need to. So parents with young children want to hear if their child's crying. People with a job that has overnight call, like many healthcare providers, they want to wake up if their phone rings and they need to be responsive to one of their patients or the hospital or something like that. So medications have been shown to not be different from placebo, are the Doxepin low dose and both of the orexin antagonists. And then do they have some medical comorbidities like sleep apnea or COPD? Some medications have a better studied tolerability profile there as well. It could be that a patient has a history of substance use disorders, we may not want to give a controlled substance, or the patient preference. The patient may refuse a controlled substance as well. Or it may be that they don't have a family history of substance use disorder, no personal history. But I've heard patients say things like, my sister took Ambien and she said it's the devil. I don't want to take that no matter what. So we have to consider all the patient preferences when making our decisions. So Jane did finally get an effective treatment for insomnia. And let's take a look at what she says about it.
I do still have the occasional sleepless night. I almost always get at least a couple of hours of sleep. But in general, I sleep 6 to 7 hours a night, and sometimes even 8, which is really nice. I wake up almost always at least once a night, but that's still so much better than 3-4 times a night. And when I wake up in the morning, I almost always feel a lot better and I feel refreshed and I'm not tired. I'm able to go on vacations again with friends, and they've all told me that I don't disturb them at all. They don't hear me snoring anymore, which is probably the biggest benefit to me.
So you really can hear the relief in her voice, and it underscores just how much the insomnia can impact our patients' quality of life. So to summarize, behavioral therapy is our first line for treatment of insomnia, but the access to these treatments may be limited. And there's still a lot of unmet needs in the treatment of insomnia pharmacotherapy, again, especially in that aging population. The current guidelines for that look at the evidence-based recommendations don't recommend most of the popular off-label treatments. And not that we can't prescribe off-label, but we should evaluate, are we using an evidence-backed treatment? Orexin antagonists may play a significant role in the way that we treat insomnia, and they're a new class, but it would be very beneficial for us to learn how to add these to our armamentarium Suvorexant has the treatment for all patients indication, but recently showed efficacy and tolerability in the patients population with Alzheimer's dementia, mild to moderate. And then lemborexant, the most recent addition to the insomnia treatment arsenal, showed superiority to placebo for aging patients and in adults in a trial that did have zolpidem active control as well. But most importantly, we need to take the time to listen to what our patients' goals are, solicit what their preferences are, and then also fully educate them so we can really engage in shared decision making with them and personalize the treatment for what they need. I've always felt that the most important things that we give our patients are not at all prescriptions. It's hope and education. And so if you take one thing away from this presentation, what I would urge you to do is that when you go back to work on Monday, please ask every patient that you see about their sleep and help them with any issues they may be having. So we're going to turn next to the question and answer period.
Wow, that was amazing. Dr. Chepke, Dr. Degramji, you guys did a phenomenal job. I learned so much. Before we get to the questions, please be sure to take this for the audience. Please be sure to take a moment to answer the polling questions again, so that you see on your screen. Now, so I have a lot of questions myself, but I'm going to stick with the audience questions. And we have a very intelligent, Elevate audience that's asking great questions. But I did want to say that I was pretty shocked that some of the things that I do may not actually be effective, like Benadryl, melatonin, trazodone. That was really remarkable. And I also appreciated the idea that the lack of belonging that Dr. Degramji mentioned, when the world is asleep and you're awake, how lonely of a feeling that might be. So these are all really interesting concepts. Now let's get to the questions. These were some of the more popular questions being asked. So the first one is, what is the best sleep aid for substance abuse patients? And I would say that for me, that's particularly an interesting question, because I do a lot of jail and prison psychiatry where they really, they're really concerned about abuse of medications. And so, I'll let either of you answer that one.
Well, I'll go ahead and start that one off. So, I don't think that we can say for any type of patient population there is one best medication. It's so personalized and individual. Certainly in patients with a history of substance use disorder, as I mentioned, then it may not be appropriate to give a medication that has any sort of abuse or dependence potential. So staying away from some of the controlled substances. However, I personally don't completely rule that out. If someone has a history of a substance use disorder and they have been abstinent and are in remission from that, it may be appropriate for those patients. We do need to treat their insomnia effectively, whether they are substance abusers or not. Certainly in forensic populations that may not even be an option. You may be limited to certain things. But in terms of current substance use disorder patients who are actively using, of course, I would say sticking to one of the non-controlled options would be my first choice if that was efficacious for that patient.
Craig, if I just amplify, the two uncontrolled hypnotics that you mentioned were Ramelteon, of course, and the low-dose doxepin. So those may be ideal for the population. A number of studies have shown that gabapentin seems to have some positive effect on sleep continuity, although not indicated specifically for insomnia. But in this substance use population, may have some benefit as well. Just to add to what you mentioned. Thank you.
What happens if you are working within a correctional facility and they don't have some of these newer medications on formulary, and really they have the standard ones that we prescribe, even though they might not work, like Benadryl, melatonin, trazodone? I mean, those are so often prescribed in the correctional setting. Is it that we're sort of out of luck and we just have to focus on the behavioral aspects of it, or any recommendations on that?
Well, I'm sorry, Craig. Go ahead. Sorry.
I was just going to say that often we do have to go off-label. The approved treatments are never going to fit everybody. So those are options, and I can't say I don't use those myself. Certainly at times I do. One thing I would point out though is that Doxepin, the specific formulation of low-dose Doxepin, it actually did go generic recently, but there's also liquid forms of Doxepin, and then also just 10 milligram Doxepin that existed previous to that in terms of treatment of depression. So it's higher than the 6 milligram approved dose, but it's in that vein of what could be used off label. So I think I've got a couple options there. What were you going to say, Carl?
No, I was going to say pretty much the same thing, that these off-label therapies, even though some of them have not been shown to work, it doesn't necessarily mean that they don't work. It's just that the studies have not been conducted conclusively on things like diphenhydramine, for example. So we just don't have data, but that doesn't necessarily mean that a clinician may not be able to utilize these things in cases where there's nothing else available.
That makes sense to me. I mean, I think that the placebo effect is certainly substantial. Yeah. And if a patient is swearing by trazodone and they say it works for them, I suppose it's okay to do that.
Yeah, one thing I'd point out is that even medications that are not controlled substances do have abuse potential as well. Diphenhydramine has anticholinergic effects. Actually, just recently, within the past month or two, saw a patient who was taking upwards of 10 to 12 diphenhydramine tablets per day to treat anxiety. And also gabapentin in certain correctional facilities has actually been banned for some of the abuse potential of that.
Right.
Yeah, it's interesting that you mentioned the Doxepin, because I recall I was serving a jail, and there was this one doctor, this one psychiatrist that would prescribe everybody Doxepin. And I was like, what is going on here? Everybody gets Doxepin. And I guess I understand the rationale now. I don't know that I would give everybody Doxepin, but I think maybe it's a good option if you don't have any other options. So, okay, so the next question is, what sleep medication is best if a patient is on a narcotic for chronic pain and chronic sleep disruption?
Well, so again, we come into the issue of what's best. We would want to worry about the potential for the sedation, that you could have some synergistic sedation. Most of the time, I would imagine most patients aren't getting 24-hour treatment. They're probably taking their last opioid medication in the evening, and then would be at a lower concentration in the middle of the night, although that may not be true. But something that has that does have a lot of sedative potential and would run into the next day. I'd stay away from things like benzodiazepines that do have mild relaxant properties and respiratory depression. Anything that potentiates the GABA tone would put the patient at a much greater risk of respiratory depression with an opiate, which is also a depressant of respiratory function. So I would say maybe something more along the lines of perhaps one of the Orexin antagonists that is more specific and less likely to compromise respiratory function would be safer.
If I could add, Craig, I think this is a population which is vulnerable, as you pointed out, to respiratory suppression in general. So before going gung-ho with more sedatives, it might be useful to get a sleep study to see if they may have some central, even obstructive apnea processes. And interestingly, if you treat these underlying respiratory conditions, in many cases their insomnia might also dissipate. So something to think about, to be more careful about this population from a medical standpoint.
Sounds good. Okay, thank you. Now, this next question kind of puts you in the position of defending the choices of the FDA, but so take it as you will. But why are Orexin antagonists controlled substances if they are considered non-addictive by most pharmaceutical companies?
So the FDA does require human abuse potential studies for any centrally acting medication. And so for lemborexin and suvorexin, they did a comparison against supratherapeutic doses of zolpidem. And it was found that they enrolled patients in these studies who are substance users, and that they score on things like drug likability, would I take this drug again, things of that nature, and at a higher than FDA maximum dose of zolpidem and generally higher than FDA maximum doses of the orexin antagonist, they scored similarly and greater than placebo when given to those patients. So that's really how they settled upon the controlled classification and scheduling out of 4. Personally, I don't think I've ever seen a single patient who has abused, misused, or become dependent on one of the 2 orexin antagonists. So I don't know if you have a similar experience, Carl.
Yeah, I mean, I don't utilize these drugs very commonly with patients with lots of drug abuse, but yeah, I mean, the decision as to whether it's scheduled or not really rests upon these basic studies, as you pointed out. And there was a signal in both of those cases to self-reinforcement and so on. So I think it's just something to be careful about. And I do think that we have lots of options, which makes it helpful for us. Yeah. Mm-hmm.
Well, we're going to need to wrap up. I wish we could go on for another hour. This has been really informative, and really appreciate both of your contributions. And I wanted to point out that the city of Philadelphia, that background, it's a beautiful city, and I think it might be a very foggy day in Huntersville, North Carolina right now, and that's why the background is like that. Anyway, bad joke, sorry. So
it's so hot it melted the glass.
Okay, absolutely, hot summer day in North Carolina. So thank you, Dr. Chepke, Dr. Dagramji, for joining us. Such excellent presentations. Up next, we have a 30-minute exhibit hall break. Check out the hall and interact with our sponsors to earn points for the Passport to Prizes competition. Remember, the grand prize winner of the competition gets a complimentary flight, hotel stay, and registration to Elevate 2021 in Las Vegas. Hopefully the pandemic will be over and we'll be in Las Vegas next year. Check the leaderboard in the exhibit hall to see where you stand. Thank you all, and we'll see you soon.